Go.
Okay. Good evening, colleagues, friends, students, and my dear friends. First of all, sincere apologies for the slight delay in starting this very anticipated program due to certain unforeseen technical issues. We welcome you all to today's webinar. On behalf of Mansarovar Global University and Mansarovar Dental College, I would like to welcome you all for today's webinar that's titled The Forgotten Killer, Oral Cancer, and How We Should Respond to COVID. Mansarovar Global University and Mansarovar Dental College has been in the forefront under the dynamic leadership of Gaurav Tiwari sir in conducting multiple webinars in the field of Ayurveda, nursing, physiotherapy, and today in dental. We are extremely honored to have with us today one of the pioneers in the field of oncology, Dr. Vijay Haribhakti sir. Sir, it's a pleasure to have you with us today, and thank you so much for moving time from your busy schedule. It's a personal honor for me as well to be given an opportunity to host Dr. Haribhakti sir, who has been an inspiration not only for me, but for a lot of young doctors who are aspiring to achieve pinnacle of success. A short but very impressive introduction of Dr. Haribhakti. Dr. Vijay Haribhakti is currently Director Oncology and Consultant Oncologist and Reconstructive Surgeon at the prestigious H.N. Reliance Foundation Hospital, Mumbai. After graduating from the GS Medical College and KEM Hospital, Mumbai, Dr. Haribhakti moved to the Tata Memorial Hospital in 1984 and trained for 5 years in surgical oncology. It was during this stint that he developed keen interest in the field of head and neck surgery and reconstructive surgery. He's been a consultant with Jasloke Hospital, Breach Candy Hospital, and Saifi Hospital, where he eventually became the chief of surgical oncology. He has numerous national and international publications to his credit, including the American Journal of Surgery. He has authored the textbook titled Restoration, Reconstruction, and Rehabilitation in Head and Neck Cancer, which was published internationally in 2019 by Springer Nature, which is one of the largest medical publishing houses. Dr. Haribhakti sir, I once again reiterate, it's a pleasure to have you here from your busy schedule. The stage is all yours. The people are waiting to hear your presentation. Thank you, sir.
Thank you very much for your kind words, Sagar. And I want to start. I want to start with a good wish, and it's a happy birthday wish actually. As you probably know, today is Gaurav Tiwari's father, Mr. KK Shri KK Tiwari's birthday, and I want to start by wishing him a very happy birthday, and by dedicating this talk this evening to him. He's a wonderful man, an extremely capable human being who has inspired me, and I think I'm so honored to be making this presentation on his birthday. So thank you very much, Gaurav, for giving me this opportunity, and thank you so much, Sagar, for the introduction. So so let me. It's a little different for me. Normally, I'm used to talking before a large, so I know what is the magnitude of the audience, and I know who I'm talking to. But today it's different. I'm just sitting in a room in my home, and I'm communicating with you. So it is different for me, and I hope it goes fine. I'm feeling absolutely great to be talking to you, and I hope I can contribute to you in some way. Let me start by a little introduction. Today, we are going to talk about two C's. We're going to talk about the original big C, that is cancer, and the now big C, which is COVID. And I think at the end of it, I would like you to tell me which you think is the bigger of the two. So let me start without any further ado with oral cancer. So if I can have, I'll just get my presentation on. My first slide. Yeah, that's right. Yeah. Okay. Okay. So I've decided to call it the forgotten killer, because today we are completely, the whole psyche is completely what I describe as COVIDized. Everybody thinks about nothing but COVID. But let's not forget this very, very, very important part of our consciousness of our country, um, and that is oral cancer. Uh, Next slide. Can I, Gaurav, can I know how to, can I change the slide myself? No, I'm not
Yes,
able.
so you can change the slide yourself, sir.
Okay, so with the right arrow?
Yes, sir, with one of the arrows. Yeah.
Okay, it's not changing. Uh, okay, it's done. Okay.
With the right arrow, sir.
Okay, perfect. All right. So, this is this is this is a huge, huge subject, as you would imagine, and I'm only going to be able to give you something like a very, very bird's eye view of the subject, and also at the same time, what I'm going to try and do is to share with you what, as dental professionals, as maxillofacial professionals, you're going to be most likely to face. And I think, therefore, we need to first get round with some fundamentals. So let us see the prevalence of oral cancer in India. This is the Globocan data, 2018. So this is for both sexes put together. As you can see, the total cancer burden is 11,57,294, of which you have a large amount, which is 1,19,992. Roughly, I would say about 1/10 of all, when you put both sexes together, that is the prevalence of lip and oral cavity. So that is a huge, huge, huge burden. But let's go still further and see the prevalence in Indian males. And here you see it is the number one cancer in Indian males. And you can see out of a total of 5.7 lakhs, 92,000 are oral cancer. In females, it contributes a much smaller fraction because the big three, that is breast, cervix, and ovary, dominate in females. But even there, it is 27,900 cases annually. So this is the kind of burden we are facing day in and day out, year in and year out. And that is what makes oral cancer extremely important in our country. So to quickly touch upon the most important epidemiological truths about oral cancer, it is, as you just saw, the top cancer in Indian males and is the sixth commonest cancer worldwide. The etiology is tobacco in all its forms, whether smoked, in bidis, cigarettes, cigars, smokeless tobacco, which includes the entire range of substances that you get. I sometimes choose to call it substance abuse because actually, if you ask me, it is much worse than the true substance abuse, because all these condiments, all these masalas, all these mavas, all of them, I think, are uniformly harmful to the oral lining. The next is chronic trauma. Now, in our country, we, as you all probably know, we have a very high incidence of dental disease with a lot of caries and sharp teeth. And people can go on literally for years and years with this kind of dentition, and that becomes a very potent cause. Poor hygiene is an important contributor to the incidence of oral cancer. Take, for instance, a country like Sweden, where tobacco in the form of snus is common, but yet the incidence of oral cancer is very, very low in Sweden. So obviously, there are other factors operational, and one of them is thought to be poor hygiene. And the others are, of course, genetic predisposition, and much less so the human papilloma virus, which currently is really hitting the headlines when it concerns oropharyngeal cancer. When you look at mortality, again, very high in males, roughly about 6.5 per 100,000 population, and in females, a little below 4 per 100,000 population. So that is a huge mortality and makes the management, the good early diagnosis of oral cancer and its suitable management extremely important. So let's quickly get down to some basics, and that is the anatomical subdivisions. As you all know, these are all the subdivisions. I will not read out everything. You know it all very well, but there are some areas I want you to note particularly, and that is if you see the dark green shaded area, which is the retromolar trigone. That is a very, very important area because once cancers get there, they tend to go backwards into the masticator space, and they lead to trismus, and they naturally progress along these routes. Another important area I'd like you to look at is the floor mouth. It looks very big in this diagram, but actually it is very small and it is kind of overlaid by the tongue. This is also extremely important and a common cause for cancer, not only in India, but also in some of the West European nations. So I'm going to spend some time on this because I think this to me represents a very important opportunity for early diagnosis for cancers overall. So pre-malignant lesions come in a variety of types. In fact, really every shape, size, and sort you can find because they need to be looked at carefully, they need to be interpreted correctly, and they need to be treated. And when there is an alarm bell to be pressed, these patients have to be correctly referred to a specialist. So I think the most important one, which all of you know, is leukoplakia. And leukoplakia is again of two types. The moment you see leukoplakia or a white patch, the first thing you need to ask yourself is it homogeneous and uniform or is it inhomogeneous? So if it is homogeneous, it is the simplex form, the less dangerous form, and it normally presents as a uniform, flat, thin white patch with a very smooth surface, and it may at times exhibit cracks on the surface. But it is the inhomogeneous form which is important clinically. And this again may present in three types. You may have leukoplakia, which is showing polypoidal outgrowths or excrescences, and that's known as nodular leukoplakia. You may find a little speckling of red on it also, but nodular leukoplakia is important, and it has a nearly 20% risk of malignant transformation, or indeed of harboring a small cancer within. Take verrucous leucoplakia. Verrucous leucoplakia, here it's a heaped up epithelium, and you find a highly exophytic, somewhat wrinkled, somewhat corrugated type of lesion, and this can, if left unattended for months and years, it can undergo malignant transformation. But another condition called progressive verrucous leucoplakia, where the patch keeps on increasing in extent, that is the one that is dangerous and can metamorphose into a cancer. And finally, the important one, which is speckled leukoplakia, in which you have a mixture of white and red. Don't worry, I'm going to show you each one of these so that you never forget them. The next pre-malignant lesion is erythroplakia. It presents as a fiery red patch, and a fiery red patch should really raise a red signal in your minds. Erythroplakia is a red signal. It is a red flag for either possible cancer or possible in situ cancer. So never ever ignore a fiery red patch in the mouth. And when it is seen along with leukoplakia, it is erythroleucoplakia. The other things that we find, which are not necessarily pre-malignant, but can in some instances show a tendency to turn malignant, are oral lichenoid lesions, oral lichen planus, lupus-like patches, and most importantly, oral submucous fibrosis. Now, I'm going to quickly take you through a few slides, and I hope it is possible for you to see these slides because I'm seeing it very, very clearly here. And 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 I wish it is seen clearly by you so that you can get a sense of each of these different types of pre-malignant lesions. So here you see a very smooth, uniform white patch, which is a homogeneous leukoplakia. This is commonly found on the undersurface of the tongue, on the cheeks, anywhere in the oral cavity. And you should know this is not a very dangerous lesion and has a liability for malignant transformation of roughly 4 to 5%. This is what I had earlier said, verrucous leucoplakia, where you can find a heaping up of the epithelium, and there you see it's right at the gum margin. Now, this is a lesion you don't want to keep quiet about. This is something that needs to be at least biopsied to tell you whether there is moderate, mild, or severe dysplasia. If there is severe dysplasia, it needs to be completely resected. Moderate dysplasia can be watched for some time, and mild dysplasia is something we can really wait and watch. This is the one I had spoken about earlier, where you find that the patch is expanding. This is in relationship to a fixture, and you can see a large patch growing in all directions, and that is a progressive verrucous leucoplakia. So mind the types of leukoplakia, and the next one, which I had said earlier, erythroplakia, you can see how it is a proper fiery red patch. This is seen on the soft palate, and that's a large one involving the entire soft palate as well as the uvula. And this is a red flag, and urgent biopsy is necessary in all patients. Now, this is the combined lesion, which is actually the commonest of all, where you see both, a little of both, erythroplakia and leukoplakia. Once you know you have ruled out all of the causes of either, so any inflammatory lesions or any fungal lesions, which, mind you, is something on which a lot of time is typically wasted. I have dozens and dozens of patients who come with large files with every kind of antifungal ointment, oral antifungals, and going on for months together. This is not right. Once you see a combination of a white and a red patch, it needs biopsy to know the degree of dysplasia. And if there is major dysplasia, it needs to come out. So these are two examples. The one on top shows a verrucous leucoplakia involving the tongue. This patient was diagnosed to be a well-differentiated squamous carcinoma finally. And the one below was severe dysplasia. So these are the lesions that we have to really, really watch out for. So if I may quickly summarize, leukoplakia is very, very important because it's so common, and it is also the most commonly mismanaged because people go on and on giving antifungals ad nauseum. That is not the way. So first, see it and define it for yourself. Is it homogeneous? Non-homogeneous. If it's non-homogeneous, is it nodular? Is it verrucous? Is it speckled? If it is speckled, it's kind of like erythroleucoplakia. It's important and it needs a biopsy procedure. If it is erythroplakia, it always needs a biopsy procedure. So this is how you need to manage these pre-malignant lesions, which you will see to a very large extent in your practice. Now here, this is a malignant transformation. You see a lesion developing posteriorly in a background of erythroleucoplakia. So this is something we cannot, if this patient had been counseled in time, he would not have gone in for an invasive cancer. But this is the sad truth in our population. And I think that is why, in some ways, I'm extremely happy I'm talking to you, because you are the people who will see a lot of these patches, and you are the ones who can really save these patients from invasive cancer and lifelong suffering. Now, this is another one. The beetle quids and the tobacco quids are very, very common in our country. And you often find in the area of the quid, you find a whitish fibrotic lichenoid lesion. And this also should be looked at with suspicion. It's related to a habit, and most certainly I would subject it to biopsy to study the degree of dysplasia. Now, this is a common thing which probably all of you have seen. Now, here, this is definitely a very diffuse pathology, typically involving large areas of the mouth, and it is very symptomatic. You'll find patients saying they cannot tolerate spices, they are miserable, and when they have that, and you see an appearance like this involving a large area, they're not typically tobacco chewers. This is likely to be oral lichen planus. And what do you do for this? If you're not sure, yes, you can do a mucosal biopsy. The easiest way to do a good mucosal biopsy is to use a dermatologic punch. I do that all the time. Just a little local infiltration, a dermatologic punch, and you get a good mucosal specimen, and the pathologist can give you a very clear diagnosis on it. And once you have lichen planus, you know, there are a number of ways to treat it, common being topical steroids. So, so this is oral lichen planus. Now, there are some patients who have autoimmune disorders such as systemic lupus erythematosus, and they can develop patches in their mouth which look like this, with white streaky fibrosis around and a red center. And these are lupus patches which may be seen with autoimmune problems. Now this, the next one, is the commonest of all. I'm sure all of you have seen it. I have lost count. I think I've seen literally thousands and thousands and thousands of patients with this. This is really what happens in our country from long and protracted use of chewing habits. It's not just tobacco, it is all the other things that go with it. Areca nut, areca quid, and all those things that go into pan masala and mava and all those things. Now, here what happens is there is a submucosal inflammation. So there is a fibrotic change coming up in the lamina propria, which then goes further down and involves the submucosa, and then produces fibrous bands which really bowstring the whole mucosa. And as you can see here, a common area is the anterior tonsillar pillars. So you can see that this is classically what happens. If this goes untreated, if the patient does not exercise and continues with habits, this is a patient who may close down completely. So please note, is there submucous fibrosis? If there is submucous fibrosis, the most important thing to do is cessation of habits and lifelong exercise. And when you say mouth opening exercises, it's not a trivial, patients just in front of you just randomly open their mouths and close it. That's not the way. It has to be a proper cycle of 6. So a strong pull down, either manually or with stakes or with a terabyte or with a screw, or whichever method you want to use, but it has to be kept down, maintained for a few seconds, and to be repeated at least 6 times in a row, and repeated several times, 6 to 8 times in a day. That is when you can get control on submucous fibrosis. So in really advanced cases who are beyond any help, we have sometimes had to intervene surgically, where we go down, release the whole fibrosis, do a coronoidectomy, and put a vascularized tissue in its place. But even these patients, mind you, need lifelong mouth opening exercises. So that is about pre-malignant lesions. And I hope I have made myself clear. This is very important, and you need to be very conscious that this is what you're going to see all the time in your practice. And this is where you can make the biggest difference of referring them to somebody, to an oncologic center where they will be correctly managed. Now, let's move ahead and quickly look at some other aspects of oral cancer. And so the most important thing is the histopathology. And as you can see from this pie chart, the majority by far are squamous cell carcinomas. And And that that really holds good. This is perhaps an international figure. In our country, I would say it would be even more than 91%. It would be more like 95% would be squamous cell carcinomas. But when you have lesions like this, you have to keep in mind certain other pathologies. For example, minor salivary tumors, very, very rarely melanomas, lymphomas, sarcomas, I mean, inordinately rare, to be honest. So it's, unless proved otherwise, a squamous carcinoma or sometimes a tumor of salivary origin. Now, in biology, what we need to know is squamous carcinomas are the commonest. They originate in the stratified squamous epithelium of the mouth. And as I said, they have a variable growth rate based upon the biology, a variable pattern of extension, and a variable degree of invasiveness. The majority are brittle, readily traumatized, and ulcerate. You can also have infiltrating thick, highly endophytic lesions, which are more aggressive and are more prone to lymphatic spread and indeed to distant dissemination. On the other hand, minor salivary tumors, which present as smooth submucosal bumps in the mouth, but largely on the palate. The palate is a very preferred site for minor salivary tumors. And here you must realize that in minor salivary tumors, the majority are actually malignant. The hard palate is an area of proclivity. The submucosal, they ulcerate late. The most common pathologies are either adenoid cystic carcinoma or mucoepidermoid carcinoma. In mucoepidermoid carcinomas, it is the grade that is very, very important. Mucosal melanomas and sarcomas are aggressive but extraordinarily rare. So this is something you will probably never see. Now, this is just to give you a pictorial idea of the kind of presentations you find with oral squamous carcinoma. You can see this one has a more or less a verrucous look. It's a very highly exophytic lesion on the lateral aspect of the tongue. On the other hand, look at this alveolar growth, where you find that most of it is under the mucosa, and it's actually gone into the mandible and perhaps produced an expansion of both the buccal as well as the lingual cortices. And that is a fairly advanced T4 squamous carcinoma of the lower jaw. The one below shows another infiltrating lesion on the undersurface of the tongue. So when you see a lesion, and I'll come to that in a minute, you really need to ask yourself, is it largely an exophytic lesion or is it an endophytic and infiltrating lesion? Because that really dictates the biological behavior. When you look at other histologic types, this is just to give you a quick idea. Now, the one to your left on the hard palate is an adenoid cystic carcinoma. The one below right is a mucoepidermoid carcinoma, and of course, the one on top on the right is a melanoma. You can see the black pigmentation. These are very, very aggressive, and it is important. The very few of them are actually treatable and salvageable. But when you do get a patient, please make sure it is the most radical procedure possible, because that is the only chance that the patient has. Now, let's go to lymphatic spread from these primary tumors. And the main determinants, as I said a minute ago, are the site, the size, the thickness of the tumor, and most importantly, depth of invasion. Again, you should know that for lymphatic spread, the tongue, floor of mouth, and retromolar trigone are high-risk areas, and you must, in anything beyond T1, assume a risk of more than 25%. In all patients, we must do a selective neck dissection to study the status of the lymph nodes in the neck. So now, patterns of spread, we now know clearly that all primary sites exhibit somewhat predictable patterns of spread, and we know that for the lip, the gum, the cheek, and the palate, the level 1, 1A is submental, 1B is submandibular, And that is the first station of spread for these primaries. However, for the tongue, floor mouth, and retromolar trigone, it can be either level 1 or indeed level 2A, which is a subdigastric node. So, uh, frequently in the tongue primary, you may only find a palpable node at level 2A, and this should not surprise you. Indeed, tongue is one of those primaries which can go straight down to level 4, and that is why selective neck dissection for the tongue should include level 4 also. So the major prognostic indicators for lymphatic spread are size, number, and extracapsular spread. So when you see a patient, what are the questions you must ask? So the major symptoms are how long and what if, for how long has the complaint been there, and is it a swelling or an ulcer? Is there pain? Is there odynophagia? Is there any disturbed speech, mastication, or swallowing? And are there any associated symptoms such as recent trismus? Very, very important, because recent trismus can indicate involvement into the masticator space muscles, and that is really frequently one of the possible, if it goes really high up there in that space, one of the possibilities for inoperability. So when and how first noticed? Was it incidental? Was it following a dental procedure? Or was it following dental trauma? What are the habits and addictions? And what are the systemic comorbidities in a given patient, such as diabetes, hypertension, and others? And what are the questions we must ask to ourselves when we see any lesion in the oral cavity? Firstly, is this cancer or is it precancer? Or can it be both together? And how best do I establish a clear diagnosis? What is the kind of biopsy that is likely to give? You'll notice that in a very flat and a smooth lesion, trying to do a punch biopsy is meaningless. You need to get a proper full thickness biopsy, and therefore we need to do a knife biopsy. And as I told you some time ago, it can even be done with a dermatologic punch to give you a nice, proper, full thickness mucosal biopsy. Punch biopsies are fine for all exophytic lesions, and they most often would give you a diagnosis. An excision biopsy is rarely necessary because we generally decide on the basis of a small biopsy on what is the next line of action. And then we have to see if there are any important comorbidities and whether there is any evidence of spread, such as local, perineural, nodal, or distant. Now, perineural spread manifests as pain. You'll often find a patient with a tongue cancer saying, the ipsilateral ear hurts, or a patient with a large tumor getting back into the space causing trismus. You may have severe temporal headache. Those are the patients where you must suspect perineural invasion, and they must be looked at very carefully. So when you go for a physical examination, we first need to do a very detailed inspection of all the subsites in the mouth. It may be presenting, say, on the tongue or on the cheek, but everything should be systematically examined, including the facial skin, do an indirect laryngoscopy or a Hopkins telescopy, and also look at the external ocular movements. So a detailed inspection is necessary, and I'll show you how clearly any intraoral lesion should be inspected. In palpation, you definitely look for induration, friability, extension to neighboring anatomical sites, and when you have the lesion between your index and your thumb, you can estimate the thickness. And that is now becoming increasingly important because thickness, the depth of invasion, really is extremely important prognostically. So the additional clinical testing we may do if there is, say, if we find that there's infradental nerve involvement, you may find a diminished sensation in the lower lip on the ipsilateral side, or if there's infraorbital nerve involvement, you may find ipsilateral anesthesia on that side of the upper lip. So this is just to demonstrate to you how you should place your tongue blades and look at, you can see how the buccal as well as the lingual surfaces have to be clearly examined even when you're examining the lower gum. And in similar fashion, the entire mouth is examined in every patient. Now, most of these patients, especially anyone other than just a pure T1 mucosal lesion, will need some kind of imaging. And I think we need to just know the basics of what really helps us maximally. Plain X-rays, as you would expect, are of limited utility. The intraoral dental X-rays are occasionally used, very, very useful. If there's a very tiny lesion in relationship to a single tooth, then then an intraoral film dental X-ray would be extremely helpful. Panorex X-rays we use regularly, but frankly, what we go for almost always, and that is the baseline of all investigations, is the HRCT. There's a high resolution CT is the mainstay of imaging, and it gives you details about soft tissue extent, the nature and extent of mandibular and maxillary invasion, and the status of the neck nodes. So CT is the first thing we need to do in any suspected case of a major oral cancer. MRI is now something we do very, very frequently when we need to know more of soft tissue detail. For example, tongue. For tongue and base tongue, I insist on MRI assessment because that alone gives you a good idea about the third dimension. This is also true for all tumors that are clinically thick, or all tumors where there is trismus, because that's the only way to find out whether there is invasion of the masticator space musculature. The other important function of the MRI is to evaluate the marrow involvement of the mandible and also neural involvement of the inferior dental nerve. So if you see thickening of the nerve either inside the canal or even beyond it, it is an important red flag, and you need to know how to plan and devise your resection. PET-CT is an important investigation also, and it is used largely when you look at primary cases. It's mainly for advanced stage 4 disease, where you want to know by the extent of neck spread, the bilaterality of spread, and you need to also know whether there is distant dissemination. So therefore, PET-CT becomes crucially important for all patients with recurrent cancer. Now, if you have a patient with a recurrent cancer and you need to decide if you want to offer any salvage treatment, PET-CT becomes your decider, because it helps you decide what is the complete extent of the disease, local, regional, and distant. Now, coming to the TNM, you know this, so I'm not going to belabor this, but you know that when you look at the T size of the tumor, it is based upon size and infiltrativeness. So you see that right up to T3, it's simple size. Under 2, 2 to 4, more than 4. And when it infiltrates, it becomes T4. Lymph nodes, again, on number, laterality, and it's mainly number and laterality. But what I want to point out is what are the changes that have happened now. In the 8th edition, which is just 1 year back, the American Joint Committee, after I think 30 or 40 years, brought in 2 major differences in the staging system. And therefore, we know that now for the T stage, for the very first time, importance is given to depth of invasion. This is crucial because we know the depth of invasion really governs the prognosis. So accordingly, you know that a T1 lesion, which has a DOI of greater than 5 millimeters, gets classified as T2. Likewise, a T2 or a T3 lesion with a DOI greater than 10 millimeters becomes a T3 or a T4 lesion. So the stage advances as the DOI increases. When you come to the nodes, the most important factor by far is extracapsular spread. And we know it is outright the most important prognostic indicator for neck disease. And therefore, we know that when there is any pathologic as well as clinical extracapsular spread, it upgrades the next stage directly to N3B, which is the highest stage in a neck. So this is what you need to know. The staging system is an expression of how advanced the disease is. And you get to know from this that what are the most important things. Yes, size is important, but depth of invasion is the most important thing. And in node, yes, the number of nodes, laterality, all that is important. But the most important thing is, has the disease gone beyond the capsule of the node? And therefore, extracapsular spread is the most important prognostic indicator. Um, so, um, so to quickly summarize, in oral malignancy, the prognostic determinants for the primary are site, size, thickness, grade, invasiveness, the invasive front, perineural spread, lymphovascular embolization, multifocality, and the pattern of invasion, whether it's today we have a number of patterns of invasion, and a WPOI5 is the worst pattern in which you see actual tumor budding. So you see around the main tumor, you see buds of tumor. You actually see them, and that is a dangerous pattern of spread. So in the neck nodes, as I told you, the most important thing is extracapsular spread, but also size, multiplicity, and laterality are important. When you come to adenoid cystic carcinoma, size is important, pattern of invasion is important, and most important, perineural invasion. Adenoid cystic carcinoma is one cancer which is very difficult to cure because of its tendency to travel along the epineurium. So that is the most important thing to look for. And therefore, in all adenoid cystics, I always ask for an MRI to look at the surrounding nerves. Is there any thickening? In that case, you've got to take your margin even higher. With adenocarcinoma and mucoepidermoid carcinoma, it's grade all the way. That's why I've written grade, grade, grade. It's the grade that matters. A low grade is curable, a high grade can become fatal if not treated in time. And melanoma is uniformly aggressive. Now coming to treatment, I think we need to know whether it's an early cancer or a moderately advanced cancer or a very advanced cancer. Surgery remains the mainstay of treatment. After all these years, after all the drugs that have come up and everything that has happened, we know that either for a primary disease or for a recurrent disease, surgery is the mainstay even today. Now, the fundamental planning of surgery is very, very important, and we need to ensure that there is a wide three-dimensional resection with clear margins. And the design of excision is essential for restoration. We need to do an appropriate neck dissection. For the N0 neck, we normally, for the oral cavity, we do a supra-omohyoid neck dissection. And for the N1 neck, we do an anterolateral neck dissection, which is a level 1 to 4 neck dissection. As I told you a minute ago, for tongue, anything beyond T1, for a T2 tongue, I would go down to level 4 in all cases. Comprehensive neck dissection is only carried out for the N2 or the N3 neck. Now, the approaches for oral surgery are many. So either through the open mouth, that is transoral, or by raising a cheek flap, by incising the lower lip or the upper lip, as the case may be. And if the lesion is very, very posterior, for example, on the base of the tongue, there may be need to split the mandible and replate it, and that is known as mandibulotomy. So when you come to the mandible, you can either split the mandible, and if you need to resect, if it is just a marginal involvement or not even an involvement, and we need to include bone just to obtain a tumor-free margin, then it's called a rim resection or a marginal mandibulectomy. And when you need to remove a whole segment of mandible, a full complete segment, it's called a segmental resection. And reconstruction, again, there's a wide variety, starting from primary closure, going on to grafts, to local, regional, and finally microvascular free flaps. Just a few quick diagrams to show you. This is mandibulotomy to show an approach to the base tongue. This is a marginal mandibulectomy for a floor mouth cancer. This is the design of a marginal mandibulectomy. to show you what is the best way of doing it. This is for small T1 and T2 lesions, the lateral tongue. This is a common design which even I like most of the time. It's a laterally based wedge, which may be either in the vertical axis or the horizontal axis, depending upon the way the tumor is located. So once you've resected, you need to ask yourself, what are the tissue elements lost? What is the magnitude of the loss? What are the functional consequences? And what are the aesthetic consequences? And to what extent is restoration possible? And what would be the most pragmatic approach in a given case? So the major objectives for oral reconstruction are aesthetic restoration of contour, color, texture of facial tissues, and preservation of facial expression to the extent possible, and functional restoration to prevent microstoma, trismus, malocclusion, incompetence, tethering of the tongue, and impaired bolus transport. So I want to quickly spend just a few minutes on understanding function. This is important because it involves you, its dentition, its occlusion, and how important it is in understanding function. So factors that preserve oral competence are the lip and the tongue. Mastication, you need occlusion, you need occlusion, and you need tongue function again. And for speech articulation, it's lips as well as the tongue tip function. And for bolus transport, again, it's the shape changes of the tongue that matter and the presence of saliva. And for deglutition, again, it's the tongue and the soft palate against which the tongue hits like a piston. So just a few diagrams to show you how the process of eating happens is the most basic fundamental thing. These are all drawings done by my very close friend, Dr. Shekhar Bhojraj. I had to sit and explain to him what I wanted, and he came up with these wonderful masterpieces, I think. So this is just before food intake. You see, for good food intake, you need a good apposition of the lips. And that is you can see, that is the oral cavity properly, which is lined by the dentition. And that is the buccal space, which is between the lips and the cheeks and the teeth. So the bolus enters the mouth, and you start with the oral preparatory phase. This is the important phase in which food is mixed with the saliva and flavors are released. And this is actually the phase which accounts for the pleasure value of food. And what really happens here is the food is broken down into small fragments, mixed with the saliva, and slowly gathered together to form a bolus, which is being readied for swallowing. So that is the oral preparatory phase. And then is the oral phase in which the whole masticated food is brought together into a bolus, which is taken back towards the base tongue. Now, once it reaches the base tongue, it's a coordinated series of neuromuscular activities that happen. And it's fascinating, and you must know it, because this is what really underlies all problems of swallowing, which are crucially important. Now, as you know, you need to block off the nose so the soft palate, which is originally down, gets hitched up and closes off the nasopharynx. You have the epiglottis, which goes down and closes the laryngeal inlet, and you have the cricopharyngeus relaxing to receive the bolus. And therefore, the next phase, the tongue is acting like a piston. It's hitting against the soft palate, pushing the bolus down, and you can see that the cricopharynx has relaxed and the epiglottis has moved down to cover the laryngeal inlet. And finally, the bolus has gone down into the esophagus all the way down towards the stomach. So this is a very, very crucial thing. I've bundled it off in a few seconds, but this is what underlies a lot of the misery and the morbidity that patients with oral cancer face. I'm not going to spend a lot of time on reconstruction because this is not a specialized lecture. So I'm quickly going to go through just a few slides just to give you a quick sense of reconstruction. And I'm just saying the lips are important because they are aesthetically important. They form a complete curtain and they have a tremendous functional importance also. And this is just to tell you that most of the lip defects that are not very large should be replaced by lip itself. So to give you a quick example, here was an elderly man with this kind of a tumor. So here we mobilize the lip, the rest of the lip with its vessels intact, and this is how it closes, and that is the kind of early result you can achieve with lip reconstruction. With lateral cheek defects, this is a very old set of slides. I've purposely put them because, you know, in all places that even do not have microvascular reconstruction, this is still a, this used to be our workhorse. Now it no longer is. We do microvascular flaps, but the pectoralis major flap is still in many parts of the world an important flap. And this is a cheek defect, and this is a bipedal pectoralis major flap, and it shows you the final outcomes in a patient with a cheek resection. This, on the other hand, is a large, 3/4 mandible defect, and you can see that's the man preoperatively. This is a fibula with a skin paddle there, and that is the on-table appearance. That's the graft that has been elevated. That is the skin, and that is the patient post-operatively. Now, this is a typical result that we should produce in almost every patient, regardless of the type. Even if it is a near total mandibulectomy, we just need to carve it out, correct out the fibula out correctly, and restore the correct shape. So this is a quick little, that was a quick bird's eye view about reconstruction. Now coming to enhancing outcomes in oral cavity, which is very, very important. So we need to have effective mouth opening, very, very important. And that's what I want to stress. Even in patients with submucous fibrosis and others, we know that the only effective remedy involves jaw stretching. And as I told you, a number of appliances can be used, such as the Therabite, the mouth screw, wooden sticks, etc. For mastication and deglutition, I think we need to remember that in the mouth, the tongue is literally everything. It is the sweeper. It sweeps around the bolus and gets it together to be swallowed. It is the speaker for articulation and the swallower, because it is the base tongue that enables swallowing to happen. So the tongue is everything. We need to, in all cases where we resect tongue, we need to try and restore the substance as well as the mobility of the remnant. And that is crucially how we need to think in terms of tongue reconstruction. Jaw movements are very, very important. And therefore, in all patients where we need a mandibulectomy, we need to restore the continuity of the mandible and occlusion. Salivary function is crucial because xerostomia, one of the most dreaded complications of radiotherapy in yesteryears. Today, we are looking after it more and more with the help of better planned and more sophisticated radiation planning in the form of 3D CRT, or indeed the VMAT or the rapid arc radiotherapy. So all these functions get disrupted by surgery as well as radiotherapy, and rehabilitation exercises are crucial to mitigate the problems brought about by all these treatments. So that brings me to the other modality. As I told you, surgery remains the mainstay, but radiotherapy is equally important, especially largely in advanced cancers in the adjuvant setting. So predominantly, it has a role as an adjuvant treatment following a typically adequate surgical resection. So the indications are large T size, a thick tumor with a lot of invasiveness beyond 6 millimeters, perineural extension, closed margins. Positive margins need a combination of chemotherapy and radiation. The N+ neck, and of course, extracapsular spread. Again, with extracapsular spread, you need to add chemotherapy to radiation. So the caveats for radiotherapy are very, very important. Dental prophylaxis, essential at the start. All damaged teeth have to be repaired, and all completely damaged teeth have to be extracted prior to starting radiotherapy. And fluoride protection has to be given, and has to be given repeatedly, even post-therapy. Concomitant chemotherapy, as I told you, is given in the presence of multiple nodes, extracapsular spread, and positive margins. Chemotherapy and other forms of systemic therapy have now come to play for oral cancer. Chemotherapy, the most important is the role of concurrent chemotherapy with radiation. All meta-analysis have proved that adding cisplatinum to radiotherapy vastly improves not only overall survival, but the relapse-free survival. So the role of chemotherapy, the most important role is mainly as a concomitant to radiotherapy for achieving good results. Neoadjuvant chemotherapy with the TPF regime is still considered very, very investigational for oral cancer. It is used, I put it here because it is used a lot, especially for inoperable primaries, but really there is no place for neoadjuvant in standard treatable cancers. Neoadjuvant TPF, that is a 3-drug chemotherapy. There is a lot more. Today we even have immunotherapy in the form of nivolumab, and we also have epidermal growth factor inhibition in the form of cetuximab, and all these are used. But for the oral cavity, the role is not so proven. Cetuximab is largely proven for oropharynx. So right now, for oral cavity, what I would like you to go back home with, the most evidence-based treatment for advanced cancer is surgery followed by chemoradiation for those with high risk lesions. So we are as far as that with adjuvant therapies are concerned. Now, just quickly before I conclude oral cavity, we must understand that outcomes are most important. Today, in fact, when we are developing new treatment modalities, the outcomes have become the most important way of determining whether a certain treatment philosophy is good and effective or not. So they are most crucial for every patient and the most important measure of all treatment efforts. Considerable variance in outcomes exists, which is based not only on disease stage, but also on individual strategies and practices. And therefore, I think these teaching sessions are important because what you do and how you devise and how you plan it makes all the difference to the patient. Poor outcomes directly impact upon quality of life and affect self-confidence, self-esteem, and productivity. Please understand, oral cancer affects people in the prime of age, the 3rd, 4th, and 5th decades, the prime of age earning potential. And if you destroy their self-confidence, self-esteem, and productivity, you've lost a useful human being. So very, very important. Outcomes focused management is what I want to very, very emphatically speak about. And you have to know that frequently outcomes is sacrificed at the altar of radicalism. I mean, you'll often hear people saying, it was that, so we cut off this, we cut off this, and so you have a neck that doesn't look like a neck, a torticolic neck, and a dysfunctional shoulder, and a completely deformed mouth. No, all of that is history. I think today is the time when patients can and should indeed be demanding, so that we don't get away with poor outcomes, because outcomes is the only thing that matters, and they have become a crucial parameter for evaluating all new treatment modalities. So finally, to conclude the first part of the talk, which is oral cancers are most prevalent in our country in Indian males. Squamous carcinoma is the predominant type. It's entirely related to habits. The diagnosis is most often obvious clinically, and thorough clinical assessment is vital, as I outlined. Surgery remains the mainstay of management. Current approaches assure restoration, and radiotherapy is a vital component of the treatment, and chemotherapy and epidermal growth factor inhibitors are still finding their way. So I know, it was a very, very quick and rushed presentation, but I don't know how much you've gained out of it, but I try to just give you a certain sense of what oral cancer management is. And I think the main things I would like to go home with are the pre-malignant lesions and, of course, the importance of prognostic determinants for oral malignancy. So let me straight away jump to the next topic, and I'll spend just 5 to 10 minutes before I close. And today, all of us are hit by this. I mean, I'm no expert. I'm not an ID expert or anything, but I think what I want to really talk about is what we as surgeons practicing surgery in the area of the mouth, what do we need to keep in mind and what do we need to know about this? Now, as we all know, this little ball of RNA, which with a diameter which is actually less than 1/100th of that of a fine human hair, has literally brought all of us to our knees, and with good reason, because there are certain things about COVID that we need to know, and I think it is very, very crucial that I share those with you. As I told you, this is not some expert lecture. I've not even put all the things I know about it. So this is not meant to be an exhaustive presentation on COVID. It is only meant to share what I think, how it is affecting the work we do. Now, as we all know, I mean, it's hard to believe that until December or Jan, or for us until even middle of February, we just barely knew something was going on. But actually, until December, nobody in the world knew anything about this. Until it was an ophthalmologist in Wuhan, China, who noticed a strange kind, a mysterious kind of viral infection, which actually reminded him of the SARS infection, which he had seen 10 years earlier. And he sent it around on certain social media messages that he was castigated for that and almost imprisoned. But no, he was dead right. He himself got affected by that and died of the pneumonia at the age of 34. So that is how COVID-19 was detected. But then the Chinese authorities did act quickly. Within a week, they sequenced the entire viral genome. And it was then established that what we were dealing with was a novel coronavirus. Novel because it is not known to cause, it is not known in human infection. And therefore it's completely novel. And it's a virus that has jumped species to get into human beings. So a novel coronavirus described with a characteristic spiky, crown look on scanning electron microscopy, and is known as the SARS-CoV-2 virus. Now, the global pandemic that has ensued has involved 200 countries. Now, I want to just, want to share a few key facts about COVID-19. So, firstly, as I said, it's actually a zoonotic virus that has jumped the species barriers. Actually, it's supposed to be a bat that had infected the pangolin. Pangolins, we don't even know what pangolins are, but they are scaly creatures which are considered delicacies in China. And from pangolins, it jumped to human beings. And as I said, being a novel coronavirus, human beings have no natural immunity to this virus. And conversely, therefore, the infectivity is extremely high. It is highly contagious and spreads by droplets, of course, and by contact. By contact, because what happens is you cough or you sneeze onto any surface and it can stay alive on that surface for 3 days sometimes, depending on what kind of surface it is. So it's a very dangerous virus. It has a special predilection for the elderly, more than 55 years, patients, and that includes me, where we are at high risk. And we need to know this is the most difficult, and problematic reality about this virus is that an infected individual may remain completely asymptomatic. So we all know that asymptomatic carriers are the real Achilles heel in the management of this virus. We need to know that a crucial measure of infectivity in a given population is what is known as the R0 value. And this is very important because a value, when the value goes below 1, it denotes that the curve is flattening and we are getting it under control. In India, we are still not there, unfortunately. But in the UK and in the US, they have gone down just below 1. Mind you, Italy as well as UK at one time were at 3. So from 3, they have come down to 1. So we have a way to go, but that is a few key facts about the virus. Now, this is the magnitude of the problem. 5,932,000 cases as of yesterday evening. I'm sure it has way crossed 6 million today. And the number of dead, 362,000 patients. This is a huge number of deaths. But the strange thing is, majority, 98% of the patients have had a mild illness and 2% have had the serious critical illness that resulted in death. That is why the huge disparity between the total caseload and the number of deaths. In India, until last evening, we had 165,800 cases with 4,700 dead. Today, I'm sure the numbers have gone up. So we are dealing with a real problem. And how does it affect us? So what are the strategies for control? We know that it's a slightly heavy virus particle, so it falls off as the distance increases, and therefore we know that within a 3-foot radius of a person who's, say, letting out the virus, it's most infective. So if you double that and take it to 6 feet, the infectivity of the virus falls very significantly. And therefore, social distancing is the most important strategy that works. The other, and very important, is hand hygiene, and do not keep touching your face. Very important. Hand hygiene, keep on washing your hands. In fact, there were some studies which showed that hand washing every hour in these outbreaks reduced the severity and the of infection by nearly a factor of 50%. So very important. Hand hygiene, repeated hand hygiene. Now we know that wearing masks is very important. We don't all need to wear the N95. We wear that only when we are operating. But otherwise, when you're in social outing, it's an ordinary cloth mask would also work. But a 3-ply surgical mask is pretty good. It has to be well-fitting. That's important. The most important thing is testing, isolation, and contact tracing. This is very crucial. Unfortunately, because of the poor availability of swabs, we cannot test as much as we should in our country. Although I think, at least in our specialty, we definitely need to test our patients. We should not be treating a single patient without testing. The management is essentially supportive. Drug treatment is largely empirical at present. I don't even want to mention any major molecule. Remdesivir has been touted a lot, but perhaps the only thing it does is reduces the extent of ICU stay. HCQS has been widely used. ICMR has advocated it for prophylaxis, but the Lancet paper has just debunked the whole thing. So we don't really know, although there are many of my physician colleagues who say that a 400 milligram tablet a week is a good protection to take for high-risk individuals. Take it or leave it. I don't take it, but I'm only saying this is one of the things that is popularly talked about. HCQS is hydroxychloroquine. But more important, we have to evolve specific strategies for each vocation. But when we talk about head and neck surgery and oral surgery, we must realize the most important problem we face is asymptomatic carriers who can harbor the virus in large amounts in the nasopharynx, oropharynx, oral cavity. So, surgical procedures involving the oral mucosa are inherently high risk. And why? Owing to aerosolization of the virus. So, when you have a virus that has a high mucosal content, and then by any procedure, or such as even a simple thing like a dental drilling or anything like that, would produce an aerosol. And what happens when a virus gets into an aerosol? It goes further and it stays in the atmosphere for a very long time. So um, the same is true even in the surgeries that we perform. Any bone cuts that we do raise aerosols. So we need to be very, very careful in all procedures that involve drilling and cutting. And these, naturally, you would understand, are worsened by irrigation. Because the aerosol, if it is large amount, it stays for long duration in the air and can infect multiple team members. Um, Therefore, oncology, and the other thing we have to realize is oncologic procedures on COVID positive patients are associated with significantly increased mortality in those patients. So COVID not only can infect the team, but it is a high risk for the patient also. And that's why, in my view, uh, when you want to take a patient up for treatment, it is crucial to test and to at least make every effort to make sure that the patient is not COVID positive. So staying safe, the possible strategies. Now for history, I've actually designed a complete declaration which every patient has to sign along with a member of the family. And here it is critically important to obtain a detailed history of symptoms and of exposure to possible COVID patients or carriers. So we need to find out how many people stay in the same house. Do any of them have any jobs in healthcare positions? Have they had any symptoms of COVID? So a detailed history, I think, is a great safeguard, because you know from the history pretty much that this is a low risk patient. Where testing is concerned today, we are following this for our major oncologic surgeries. We do 2 successive negative swabs taken at 48-hour intervals, because the false negative rate is as high as 30%. So in order to minimize this, we do 2 swabs 48 hours apart before we decide to take up a patient for major surgery. Furthermore, in any patient where we still have any doubt, or in fact, in all patients with a very major surgery, instead of doing a plain X-ray chest, which is the common thing, we do a plain CT chest, because the CT appearances of COVID are very, very classic. So we do all these to try and screen heavily and make sure that we are not operating on a COVID positive patient. However, we have to realize that it is impractical to carry out all the above for routine dental procedures. So for that, we need to think differently. So I'll just talk about the guidelines for major procedures, and then maybe in the questions and maybe in the to and fro, we can see what we can do with not so major procedures. So the guidelines for major oral cancer surgery is restrict only to essential procedures without which the patient is at serious risk. So, a rapidly advancing malignancy, or on the other end, an early, highly curable malignancy. So we need to know that we need to prioritize and make sure that this is absolutely essential for the patient. We need to take all the precautionary measures to take a declaration, do a twin swab, do a chest CT, and then only schedule the patient for surgery. We have to limit the number of staff in the OT. When the anesthesia team is inducing, we enter the theater 10 to 15 minutes after they have induced, to avoid any of the aerosol that might be produced at the time of induction. And we avoid any procedures on COVID positive cases. And even in highly screened negative patients, we follow strict universal precautions for all cases. There is full protective gear, the PPE, the N95 mask, and the powered air purifying respirators. Now, this is a somewhat ungainly equipment, but it's used by the orthopedic surgeons to do joint replacements. But we have started using it for our procedures because that seems to be the surest way to protect you from aerosol injuries. So these are the guidelines that we recommend for major procedures. Now, for minor procedures, I think I still feel it is important to take a detailed history, and it is important to have at least one swab. I would say even for routine dental procedure, I would think it is necessary to be sure that you're not operating on a COVID positive patient. The risk is just not worth taking. So finally, when we talk about oral cancer and COVID, the shifting paradigms, managing early cancer, we are making all attempts to offer a highly effective single step treatment in the form of surgery. So we take very wide and clear margins to obviate any need for, because one of the indications for radiotherapy or chemoradiation is positive margins. So we take, we make every effort, we get to know the margins on table so that there is no doubt at all about the adequacy of surgery. And as far as possible, we use surgery as the single modality in all early cancers. And in advanced and operable cancers, we know that we anticipate delays in treatment, and therefore we are using a number of strategies. Neoadjuvant chemotherapy with 3 drugs is common, but frankly, we've been using oral metronomic chemotherapy, which is a publication which is going to come out tomorrow at ASCO. It's going to be presented by Tata Memorial Hospital. It's amazing. It really helps oral metronomic chemotherapy in preparation for delays for surgery. So that's what we have been using. And finally, when we are managing recurrent, advanced, and inoperable cancers, again, we are using metronomic chemotherapy or immunotherapy. The essential aim is to minimize hospital-based care in these patients. So if I were to conclude about COVID and healthcare, I would say the global pandemic has had an unprecedented impact upon the nature and the economics of healthcare. And it goes without saying that patients with oral and head and neck primaries constitute a high-risk group. And for the foreseeable future, I think for a long, long time to come, the routine practice of oral surgery will need protection and PPEs. We need to be ready to be uncomfortable and operate with all the protective gear. And therefore, I think I would add with a somewhat prophetic statement that oral maxillofacial surgery will never quite be the same again. So thank you. I think I've taken a long time. I'm not sure how long I've taken, but we started late. And thank you very much for your attention. I don't know how many participants. I see 472 participations. Thank you so much for being here, and let us now go to the questions. So who's Sagar? Is that something you're going to handle? How are you going to coordinate the questions?
So first of all, I must like to say this was a fantastic lecture, a perfect blend of theory and practical information for us dentists. And of course, we've had a lot of participants from other medical fraternities as well returning. So I'm sure it's been a very, very informative lecture. There have been certain questions that have come in. I'd just like to transfer the same to you, sir. Yeah. So very, very commonly asked question. This one comes from Dr. Romaila Naeem, who asks, what are the roles of multivitamins and antioxidants in treating oral submucous fibrosis? In fact, sir, oral submucous fibrosis has been a very popularly asked question, yes, and it's a condition we as dentists see very routinely. Yeah. So how would you guide us to handle a situation like this in our practice?
Yeah. See, it's like this. Antioxidants and vitamins, to be honest, have empirical value. I mean, but but these patients feel they are getting something, and I don't think it's harming them, but we should not let them go away. My response to that question is, please do not let anybody go away thinking that vitamins are going to take away submucous fibrosis. The first thing I would say is submucous fibrosis is there to stay. No matter what you do, it is incurable. After all these years, I am saying that with all humility. It is not a curable condition at all. So no amount of vitamins and all are going to make a difference. We need to live with it. We need to stall it by stopping all tobacco habits. And we need to give regular jaw stretching exercises. So that is, I think the clear message is, apart from all the antioxidants and all that you may want to give, please understand, tell the patient this is not going to go away. So just as you brush your teeth every morning, please do your jaw stretching exercises. And of course, stay away from all habits. So
thank you, sir, for that answer. There's another question. This comes from Dr. Shivam Dubey. He asks, what is the MOPP and CHOP regime for in chemotherapy for treating conditions?
No, those are for lymphomas. They don't concern you. The CHOP regime
Okay.
and those are meant for lymphomas. They're for
Okay.
for lymphomas, and I think it's completely not a part of of your interest, or frankly even my interest.
Okay.
It's a medical
Okay.
oncologist. It's a medical oncologist who deals with lymphomas, and so these are
Okay.
done by the medical oncologist. Yeah.
Okay.
Yeah.
Sir, is there anyone that we can have a hand raise and directly connected to sir
Yes,
from
yes.
the Mansurova team?
We have three people who have raised hand. Hi, sir. I wanted to just handle the technical, but I thought I was still sticking onto my chair, listening to you talking. Layman like myself can also understand, what you were saying.
Yeah.
I think the best part. Yeah, we've got three people who have raised their hands. This is Sham Sundar Reddy and Sashwat Mishra. I've allowed both of them to talk. Any one of you can, go ahead and ask a question. You can unmute yourselves and you can go ahead and ask a question if you want. I think.
I see a question here. Which no, it's a quick poll. Best treatment for cancer. Oh, that's for the okay.
Yeah, that's a poll survey.
Oral cancer. Yeah. Okay. Yeah.
I can hear. Can you talk, please? No, I'm not sure about it.
Is it working?
It's working, sir, but I guess there's Ashok Kumar Chaudhary, Akriti Das. Akriti, you can go ahead and talk.
I think they have to unmute. Please tell them to unmute. Yeah.
Please unmute Akriti. We don't have much time. Yes, please talk.
Good evening, sir.
Good evening.
So my question is related to GIST tumor.
To?
Hello, can you hear me?
Yes. Yeah.
So my question is related to GIST tumor.
No, it's not very clear. I think I heard her say something like gist. Did I hear her right?
Yes, sir.
Yeah. So that's a gastrointestinal stromal tumor. That never occurs in the oral cavity. It's as the name suggests. It's a tumor that presents in very often in the stomach or in the esophagus, and the important thing for you to know is this is one group of tumors where oral therapy has become very, very important. So imatinib has really made a very big contribution to the management of GIST. But this has nothing to do at all with the oral cavity. It never ever presents in the oral cavity. It's mainly in the GI tract, mainly in the stomach and the esophagus.
Yes, sir.
We have got a question from Dr. Sanjeev Khanna, Sagar's father,
Yeah, yeah,
in the Q&A section.
yeah.
He's saying, he's actually written a small letter for you, sir. He's saying, Dear Dr. Haribhakti, superb talk. Why not KOLs like you influence government bodies to legislate against the pan masala and tobacco lobby?
Oh, it's going on. It's an ongoing battle. It's going on. All of us do it, and it's very much going on. How can it not go on? That's a very important effort which goes on. Clearly goes on, but you've got to realize there are economic reasons why it cannot be enforced, and the problem is, I mean, we've seen that when you try to enforce a ban, people get it the wrong way. In Maharashtra it was banned by Sharad Pawar, but you know what, I mean, anybody and everybody can get it through the back route. So it's a very complex problem. If you ask me, I think it's a very important area of emphasis, and I personally am feeling right now at this stage in my career that that is where I want to spend increasing amounts of, when I can pull myself away from from patients. I would like to spend time on understanding why people choose addictions, and see if we can help them, because I think that is our only salvation. We just cannot win with, I mean, all the big operations we do. How often can we do them, and in how many patients are they successful? So we have to realize that the prevention is the way to go. So it's a very important question, but very difficult to really answer, because I think it's human habit which has to be understood, and and acted upon. So thanks for your question. But I think it's an ever present problem in our minds, and all of us try to solve it in our own little ways. I give lectures in various fora and do all those things. I don't hesitate to talk to all our liftmen and watchmen and whoever I encounter. I I don't differentiate. I think all of us should do that, and try to minimize this habit. It's not one person who can do it. It's not even 100 people who can do it. You need the whole population to rise against it. So
We have got Vinay Sharma, who's again, willing to ask a question. Vinay ji, you can go ahead and ask one. Vinay Sharma, can you hear us? Yeah, you please go ahead and ask your question.
Yes, sir. I wanted to know that if anyone have the pointed white patches on their tongue with pain and during investigation and burning sensation during that time. So and the redness around all around the white patches in the tongue and redness in between them. So what will be the diagnosis of this, and what is
yeah,
the treatment of this condition, sir?
okay. No. See, it's extremely difficult for me to, as I told you, I don't know. I don't know if those pictures could be seen. Could they be seen clearly? All the various lesions which I
Yes.
show.
Yes.
But I don't know. You see, it's very very difficult. What you're describing could either be oral lichen planus, which is affecting the tongue, but I don't want to give a clear answer. I think you need to see it, you need to feel it, and you need to find out whether the patient had tobacco habits or no. So I think it's a many layered answer, if I may say so. This is not something, there are no stock answers to this, because that's why I told you the patches come in, oral patches come in a variety of forms, and it's our duty to try and understand them. Um, this is, if you ask me, it's the one of the commonest causes of mismanagement, because you can't diagnose it. So my suggestion is, go through all the questions with your patient and try to reach it. And if you cannot get a tissue diagnosis, and then treat the patient, But from the way you're describing it, it could be oral lichen planus if the patient is not a tobacco chewer.
Right, sir. Now we have Dr. Nitin Avasthi. He is an associate professor with Mansarovar College as well. Nitin, you can talk.
Yeah.
Good evening, sir.
Yeah. Good evening.
Sir, I must say it's a very, very wonderful lecture, and it was a pleasure hearing you, sir.
Thank you.
So my question is, as you have told that it affects the quality of life of the patient. So right from the pre-malignant lesion, while the patient is undergoing chemotherapy, radiotherapy, and the surgery, and after the treatment, so what should be the psychological counseling of the patient? I think so. It's a main treatment part. So what should be the psychological counseling of the patient?
Well, of course, I think, see, as you said, now in a patient who presents with, say, a pre-malignant lesion, I think the whole effort, the whole counseling effort has to be against the habit, against chewing habits. But the whole equation changes once the patient has a cancer, and once the patient needs a major intervention like a surgery, then the whole thing changes. And if the patient also needs reconstruction, or if the patient has a recurrence, and then so the whole goal and the approach and the counseling will be very highly individualized. So I would answer your question that way. It's highly individualized, and you've got to see what a given patient needs most, and then try to custom make the answer for each patient. It's very difficult. You can't tell, you just can't equate all these groups of patients. They all need a very individualized form of approach and management. So, I mean, say if it's a patient with major swallowing problems, yes, I know swallowing therapy can make a very big difference. But you need to understand that there will be a small fraction of patients who will just not be able to swallow normally, who will be tube dependent. So you need to even counsel those. So all I'm trying to say is, when you encounter all kinds of patients, you know that the same solution cannot apply to all. You have to tailor make it to the patient. So
There are some more questions in Q&A, Sagar, if you may take them up. If sir has,
Yes, sir.
sir, that is, if you may allow us to. There are some more questions in Q&A, so
Okay, so this is a good question. This comes from Alexis Anthony. He asks, I wanted to know the difference between FNAC and biopsy. When you have a doubt of malignancy and you get a very specific diagnosis using biopsy, then why do you do an FNAC rather than easily getting a definitive diagnosis through biopsy?
Okay. So I'm glad you asked it, because the two address very different situations. FNAC is only done for a node, for a node, and for a node it is the right thing to do. You should never try to biopsy a node, because that is the wrong thing to do. You make an incision on the neck which you may not be able to encompass in your neck dissection incision. So if you want to diagnose cancer in a node, then it is better to start with an FNAC, because you just use a small 23 gauge needle, which causes no disruption of the planes and can give you an excellent diagnosis with a very minimal procedure. If the node is small or slippery, you may do it under ultrasound guidance. Biopsy, on the other hand, is for the primary. Now, there, what I was saying was, it's the type of biopsy that's important. Now, if it's a brittle, fairly exophytic growth, then a simple punch biopsy will do the trick. You need a good punch, and that's all. You need to spray a little bit topical, and you can do it. But if that is not possible, if it's a flat lesion, as I had said during my lecture, if it's a mucosal flat lesion, then you need a knife biopsy, or, as I told you, a dermatologic punch biopsy. So I hope that answers your question. They are not interchangeable. FNAC is only for nodes, and biopsy is largely for the primary. So they are two things that serve two different purposes. Yeah. I hope that clarifies your doubts. Or
Yes, sir.
yeah,
Yes, sir.
yeah, okay,
Certainly.
yeah.
So can we take one more question? Would
Yeah.
you have the time with us?
Okay. Yeah. Yeah. It's already 7. Yeah. Yeah. Sure.
Okay. We'll take this last one, sir.
Yeah.
It comes from uh, Pallavi Singh. She says, I wanted to know what is microstoma.
Microstoma is when the diameter of the mouth reduces and you have a small mouth which looks like a whistle. It's called a whistle deformity. So when you've got to take when you've removed nearly greater part of the lower lip, and you turn the upper lip, you take flaps in the upper lip and join them together, just to enable the patient to shut the mouth. It's called microstoma because it's a very small mouth, and that's dysfunctional also. You can't eat properly, you can't do anything properly with a small mouth. So that is what microstoma is, and that should be avoided at all costs. And that's why I gave a quick idea about reconstruction, because I just said you have to try and restore the anatomy uh, and the physiology of all the very important structures of the mouth and the face, because they affect appearance as well as function in a very big way.
Thank you, sir.
Yeah. So okay, so
One question which I think is very relevant here. I'm sorry, I am again
yeah.
including here. Dr. Amita Gupta is asking, is betel nut is carcinogenic or tobacco with it?
See, it's like this. Uh, Betel nut uh, definitely is a part of many of the mixtures that patients have, and we have seen that all these mixtures are carcinogenic. Now, uh, to answer a very specific question, of course, tobacco is the known. It has been established. It has a nitrosamine content, and it is clearly and incontrovertibly a carcinogen. But if you ask me, betel nut is equally much. All these things act together. They act synergistically, and they contribute towards cancer. I did not say anything about alcohol, but I have to say that alcohol is also an important potentiating factor, because if you have, uh, for example, in France, people drink a lot and they smoke a lot, and in those patients, very high incidence of tongue cancer because of smoking as well as drinking. So when you drink, the alcohol gets secreted into the saliva, and the concentration of alcohol, which is an irritant, rises inside the mouth, and then you have smoke, which irritates the lining. So it is how each carcinogen acts that determines its importance. As far as areca nut is concerned, I mean betel nut is concerned, uh, it's I'm uh, I mean, nobody has really done independent research on it and given a clear evidence-based answer on it. But let me tell you, it's been so many years, and we see day in and day out there patients who say we don't eat tobacco, we only eat these condiments, and they also develop cancer. So so I wouldn't choose between the evils. I would avoid all of them.
Thank you so much, sir.
Yeah. So okay.
Right.
So,
Thank you so much. It's been such a pleasure to having you on this platform, and more than 500 students on Zoom, and about equal number on YouTube for watching on and off. And yeah, it's really interesting to see how technology has helped us uh, achieve this. And we couldn't have imagined somebody of your stature to come and talk to these students. And now when it has happened, it's really a blessing disguise for us. Thank you so much once again, sir.
yeah, most welcome. And I really hope this has been useful. And I know for many it might have been a bit too a bit too much and a bit too intense. But I think uh, you know it's important to just be aware. I feel it's important. Even awareness is important, even if you're never going to do that kind of surgery. If you know what are the possibilities, you can guide your patients better. So I think from that point of view, it is important. And as far as COVID is concerned, I think it affects all of us. So we all need to pull up our socks and protect ourselves. It's very, yeah. So okay.
All right, sir. Thank you so much. This is should be it if our host Sagar allows us. I guess this is. This is
Thank
the-
you so much, sir. On behalf of Mansarovar Global University, Mansarovar Dental College, we appreciate the time you've given us from your busy schedule, and we extend our warm thanks to you once again, sir. Pleasure to have you at ours.
Thank
Thank
you.
you, sir. Thank you very much.
And God bless all of you. Yeah.
Thank you,
Okay.
sir.
Thank you, sir. Thank you.
Good night and good evening.
Bye bye, sir. Good
Bye-bye.
night, sir.